Good afternoon. Welcome to the Michigan Center for Rural Health Grand Rounds. My name is Renee Hawkins. I'm the Education Manager with the Michigan Center for Rural Health. The Michigan Center for Rural Health is a nonprofit state office of rural health, and a cornerstone of our office is providing free education to rural healthcare providers. I'll be the facilitator for this program, and I would like to welcome everyone to today's Pediatric Grand Rounds. This program is jointly provided by the Michigan Center for Rural Health and the Michigan State University College of Nursing, the Michigan Social Work Collaborative, and MSHWA for their continuing education. This session provides one contact hour for social work, community health workers, and physicians can self-claim this hour. And I would like to introduce Adrienne Wilkerson from the MSU College of Nursing with the professional development information.
Thank you, Renee. So as you can see, today's activity is providing one contact hour of nursing continuing education credit. We provide our provider statement on the screen for you to see, and we can skip forward to the next slide, Renee. Thank you. So for criteria for successful completion today is that you're participating in the learning activity, which is you're all logged in and doing. And then also we need you to complete the post-session evaluation and survey at the conclusion of the session. So we'll provide the link in the chat at the end of the session and a QR code in case you want to use your phone to complete that. And we also like to make note that when you're doing that evaluation, it's best if you can complete it pretty quickly at the end of the session is ideal. We understand not everybody can do that immediately, but if you can even do it tonight or tomorrow morning, that just helps us to facilitate the closing of our events in a timely manner. And we appreciate that if you can. Commercial and financial disclosures. So no one with the ability to control content of the activity has a relevant financial relationship with an ineligible company to disclose. And there are no commercial interests associated with today's activity to disclose either.
Here we go.
Thank you. And then the learning outcome for today is we hope that you will all have increased knowledge of the risk factors for suicide in young adults and adolescents and the basics of a safety plan as well.
All right. Thank you, Adrienne.
Thank you, Renee.
With that, I would like to introduce our presenter today, Dr. Zakia Alavi. Dr. Alavi is a child and adult psychiatrist, and she is currently serving as an associate professor in the Department of Pediatrics and Human Development for the College of Human Medicine at Michigan State University, where her primary role is cross-discipline teaching for primary care pediatrics. Her clinic work is based in the community mental health system in Jackson, Michigan. And thank you so much, Dr. Alavi, for being here today. We truly appreciate your time and your willingness to do this for us. So thank you so much.
You're welcome. It's great to be here. Thank you for inviting me. Bear with me just a couple of seconds. I'm gonna struggle to share my screen here. So, okay. What do you guys see now?
We see your whole presentation. So with the slides on the
so the cursor moving?
Yes.
Okay. All right. So I need the presenter view. Where did that go? Anyone else has Zoom fatigue? Okay. Just, I'm trying to make it so I can see faces. I'm just tired of not seeing people. Don't know why it's not letting me do that. Okay, well. Is my view limited to just one person at a time, by the way?
So you can change your view. I'm not sure what your screen looks like right now, but up in the top right corner, there's a button that says view, and you can change it to gallery view, so you can see more people, as opposed to speaker view or standard view.
Yeah, it's not letting me do that.
It's probably, I do think it's more complex when you're the speaker.
Yes, yes, I agree.
If you'd like, I can pull up your slides for you.
Oh yes, please, could we do that?
Sure,
Thank you.
let me grab them quick. I didn't have them up though, so I had to pull them.
No, I'm gonna try sharing again. Maybe it's easier if I do it, because how am I gonna move the slides?
You can just say next, if you would like. Oh, we
Oh,
see it.
this is it.
Yep.
Awesome. Yes, and I see it too. Perfect.
Perfect.
Okay. So I don't know how many of you are physicians and nurses versus other healthcare providers versus mental health care providers. Do we know?
We can have people, if you want, people can put their things in the chat and we can get a gauge that way.
That'd be great. And then I don't know how to take a screenshot of the chat, but I'd need to know anyways for my reporting purposes. So,
and we can follow up on that afterwards, because everybody registers and gives us that information.
Awesome.
Too.
Thank you. Thank you. Lovely. So I have no conflicts of interest. Let's just move on to the learning objectives. So these are, broadly speaking, our learning objectives, and feel free to, I can't always see if you raise your hand, but just chime in if you have a question or you want me to stop and address something. So suicide in youth, we've been hearing a lot about in the medical circles, in the media, because it's an emergency for us in the US, and I think in some case, in some respects worldwide. But to understand suicide, I really like this slide. It's like a complex puzzle. What makes a person wish they were dead versus act on that thought versus complete the thought, and then how do we look at the overall risk of people having the thought, completing the thought, and what goes into completing that action? So are there modifiers? Because that's sort of what, that is the most important thing for us. As you can see, the risk of suicide has multiple pieces, the intent, the planning, history, the environmental factors, certainly psychiatric disorders, and then the availability of lethal means. So I want to just take a second to say this. A lot of times when I do these presentations, when I go in, the overall thought is that if there is a psychiatric condition, then the risk of suicide is automatically higher. And if there is not a diagnosed psychiatric disorder, then it doesn't necessarily play a part. And I just want you to know that that is not the case. I don't, perhaps this group doesn't think that, but a lot of times people look for an underlying psychiatric disorder when there is a suicide that was either completed or attempted. And many times it's there, but a lot of times it isn't there or wasn't identified at the outset. And that's where a lot of these things, these three things, come into play: the availability, the environment, the person's characteristics, impulsivity, and hopelessness. If you think about it, not all of them translate to a psychiatric disorder. So just wanted to put that out there. So the numbers now, these are numbers from 2018. There have been some new numbers that have come up, but they're still being tabulated because, of course, COVID put everything on a hiatus. But if we just look at suicide itself as the leading causes of death, up until 2018, it was the 10th leading cause of death, all genders, all ages, across the board. In US, it was the second leading cause of death among youth and young adults, and then ages 25 to 38. This is the scary piece, in ages 10 to 14, it was the third leading cause of death. So I'm still looking at new numbers, and they are being tabulated as we go through this year, 2023, but it's looking like for ages 10 to 14, it's going to also be the second leading cause of death, if not the first, definitely the second. So the numbers are frightening and ominous. So this is a little bit old data because I don't have newer data. It's still being worked on. But this is what we had in up to 2017, people dying in Michigan. And then the state of Michigan ranked at that time 34 out of 50 in the states with high percentages of suicide. We think that number has actually risen, but that's still being worked on. So wait, did I skip a slide? No. Okay. So what about NSSI, which is deliberate self-harm or non-suicidal self-injurious behavior? Do any of you, are you guys, I'm sure you've seen it. How many of you have seen this versus a clear suicide attempt? I wish I could see faces and hands, but I can't. Okay, I see maybe one hand, thank you. So it's way more common, right? Especially if you work in primary care or in the emergency department. This is by far the most common thing that you will see in this context. How do we describe that? We describe NSSI, or non-suicidal self-injury, as a deliberate, purposeful, but non-lethal self-injurious act engaged in, with or without suicidal intent. And it's really important to have that definition and that qualifier, with or without suicidal intent, because sometimes you'll get someone this is like their 10th visit to the ED, for instance, and they come in with these superficial slashes on their thigh, perhaps, or the wrist, and that is your NSSI, or self-harm, perhaps without intent, but even that can lead to suicide or death, even if there was no intent, just maybe a deeper cut or for whatever reason. So all of these things need to be looked at seriously. So the term parasuicide actually is an umbrella term that encompasses attempts as well. So attempts that are not successful, and then non-suicidal self-injurious behavior. And the typical reported age for onset of NSSI falls between 12 and 14 years of age. Now, that when I was preparing this presentation, that was, and I'm a child psychiatrist, that really was sort of a rude awakening for me, because I didn't think it would be that young. I'm sad to report that in the years since the pandemic started, I'm seeing this age shift more to the left, just anecdotally in clinical work, going more like 10, 11 rather than at 12, because we used to think that 12 is the magic number because puberty. Well, that's changing now. This is another slide I borrowed with permission from a colleague. And it's a good way to look at when you see suicide or suicidal behavior or parasuicide. So suicidal behavior, attempt, self-harm, all of those things. it helps to have a model to understand and to put things in context. So you look at the actual suicidal behavior, and then you look at proximal risk factors, which, as you well know, are risk factors that are in terms of time, temporally speaking, closer to the actual event or the actual behavior. But then you look at the distal risk factors. For the most part, the proximal risk factors are risk factors that are the most modifiable. They are the ones that you are more likely to find in your encounter with the patient in that moment. So let's start with more distal factors. And those are, again, factors that are some degrees removed from the actual event. If we say event T0 is the time, or T0 is when they attempted to hurt themselves or attempted suicide, distal risk factors would be at least 5 or 6 degrees removed, very important, but not necessarily operating just before the event. And so these are characteristics in a person, vulnerabilities that increase the risk for suicide. And what are some examples? So your psychiatric disorders sit firmly in this category. They sit in both, actually, but here they really do play a role. They play a role because they determine a person's cognition, their coping skills, the way they think, the way they respond to the environment. Family history of suicide is completed or attempted is a big flag. History of suicidal behavior, the more attempts, the more NSSI episodes you've had, the higher the likelihood that you're going to have completed suicide, or at least a severe attempt. Again, talking about distal risk factors. So let's just look at this, take another couple minutes on this slide. So over 90% of youth who complete suicide meet criteria for at least one. Over 80% of youth who attempt meet criteria for at least one psychiatric disorder. Making sense so far? Okay. Then we look at mood disorders, and the picture changes a little bit. Over 70% who attempt, adolescents who die by suicide, and 50% attempters meet criteria for mood disorders. The risk is higher if anxiety is present. And then if there is true bipolar disorder, 33% of youth with bipolar disorder have attempted suicide. So what I want you to pay attention is here. 50% attempters meet criteria. 70% who die by suicide meet criteria. Remember what I said earlier, mood disorders, psychiatric disorders definitely play a part, but look, the numbers are alarming, because what about the other 30%? What happened there? And what about the other 50% in terms of attempters? What happened there? So then we look at more distal risk factors. We look at substance use disorders. Why? Two different ways of looking at it. I'll start with the second one, which is the stress diathesis or stress model, which is you engage in an episode or binge of using whatever it is, and either during the time that you are intoxicated, or quite often the time that you are actually withdrawing or post-intoxication status, leads to these sort of negative affect, negative emotions. The brain has typically the neurochemistry, the neurobiology of any substance use, be it alcohol, nicotine, cocaine, cannabis, whatever, is that you get the buzz because you release all the stored neurotransmitters when you use a certain substance, which is what gives you the buzz or the high. So then when you release all the stored chemicals that you were probably going to use over the next several days or weeks, you then immediately in the aftermath, after the high subsides, you have this crash, right? We've all seen that. And that crash is so, the word is dysphoric, that it can lead to suicidality. If there is access to lethal means, if there is the right combination of access, as well as the environment, which may or may not be more or less conducive to a certain to how they're feeling in that moment, then it can lead to suicidality. The second model is not that far removed from the one that what we just talked about, and that is the self-medication model. Now we hear about this a lot, in fact, in substance use disorder clinics, where a person comes in and the history is that they've been using for a long time. They come in for either rehab or for some other reason, and it turns out that they started using a long time ago because they were self-medicating. And by self-medicating, they were medicating to reduce all the things that actually they can experience after they crash. Does that make sense? So you start out with this model of you're self-medicating for some symptoms, you use the substance, it leads to this again, and then leads to suicidality. So it's in many ways a closed loop. Which came first, the chicken or the egg? The key here is, even with substance abuse, being self-medicated, medication, a method to self-medicate, even so, a lot depends on access to means, on availability of lethal means. And you'll hear me talk about that a lot, because that is the single biggest modifier that we can actually modify or influence. Some more, and I've had colleagues who find the term psychopathology a little distasteful, and I respect that, but I've left it here for a reason. It's not a pejorative term. It's not a negative connotation by any means. It really just refers to the brain and the fact that disruptive behavior disorders truly are disorders of the brain, in that it is truly a pathology of the brain. And so what are some disruptive behavior disorders? I wish I could see people. I'd love to know what people think. What do you guys think are some disruptive behavior disorders? Thoughts? Anybody can speak up? I can probably hear them.
Yeah, you can come off mute or type it in the chat, please. Thanks.
And I can't read the chat. Can someone read it
I
to
can
me?
read it off. Yeah.
Anybody? Okay.
Acting out, violence at home or school.
Absolutely. Yeah.
Skipping
And if we
school.
sorry, go ahead.
I was just going to say skipping school.
Exactly. And so all of that. And then if you think of DSM-5, if you look at, more of a textbook definition, the disruptive, that section has things like ADHD, things like oppositional defiant disorder, things like conduct disorder. And if, again, everything that you guys have said absolutely goes with all of that. So we're still talking distal risk factors, and let's look at some developmental. So ages, younger kids, older kids, pubertal kids, young adults. So any age where you are more likely to be impulsive and emotionally reactive, the risk is higher. So what ages are those? Teenagers come to mind, right? So quick brain fact, and that is the human brain, it grows the majority of the brain growth occurs in the first year after birth, and then the rest of it happens by age 6. And after that, there is still some brain growth, but most of it is in relation to each other. So during teenage years, the frontal lobe of the brain is actually size-wise smaller than the midbrain. I mean, it literally is just hasn't grown to come up to the level that the midbrain is. The midbrain is really much more active and larger in size as well. And teenage, that's why it's associated with impulsivity and emotional reactivity, because those are all things of the midbrain. The frontal lobe is the where you think, it's where the brakes are. And the poor teenagers, their brakes are sort of not developed. So they are more impulsive and more reactive, brain-based developmental fact with all of us. And so they are at higher risk. The other thing, developmentally speaking, is impulsivity. So you see impulsivity, we're talking developmental now, you see impulsivity in certainly in teenage patients because of what I just said. But impulsivity is also seen in younger kids before they are teenagers. Why? They're just young. So impulse control is something that develops over time, and it's a function of maturing of the nervous system and myelination of the neurons. And so developmentally speaking, impulsivity is the middle name for kids that are not in their teenage years. So again, access to means and restricting access is a big factor for the younger age. And if you're looking at suicide, impulsive aggression, developmentally speaking, is another factor which is seen in certain types of people. It is sometimes seen in certain families. You can see impulsive aggression in families, in young people that have grown up in a dangerous neighborhood or under very traumatic circumstances. They are easy to trigger, and when they feel threatened or they feel in any way threatened, then their go-to is responding with aggression, because they are responding to a threat. And again, depending on what the means are, if they can't take that aggression out on others, it turns on itself, turns inwards, and can lead to a behavior that is akin to suicide or self-harm. More risk factors. Having sexual minority status is a risk factor. I'm not going to read the slide, you guys can all see this. And we're becoming more and more aware of this as we are, as a society, becoming more comfortable with discussing sexual minority status and how it plays out in our overall social context. This is, of course, goes without saying. I want to say something here that the slide doesn't say, but I should actually put PTSD. I've worked with some families, kids of families that the parents are veterans and had high levels of PTSD related agitation and depression and substance use and so on and so forth. And I've seen a lot of depression, but also suicidal behaviors and suicidal thoughts in kids coming from that background. So this, the family history and what's happening in the home is a huge one in terms of a risk factor. We've talked about that. So I'm gonna take a moment. It's 12:31. Thoughts, questions, comments before I move to the next few slides? Okay.
Go ahead and unmute yourself or type it in the chat. Comment, the statistics are unnerving.
Indeed, you're right. They are. They are. And as we move through the presentation, you will see something else that's unnerving, how avoidable some of these things are. It's really sad how avoidable some of these things are. So then let's move to proximal risk factors. And like I said before, these are proximal to the actual event, either the attempt or the completion of suicide or a self-harm behavior of some sort. So factors that increase at risk, and the top of the list, and I'm not making this up. This is coming from the medical literature. The top of that list is, in proximal risk factors, access to means, intoxication, conflict with a loved one, and recent breakup. The recent breakup piece is huge for teenagers. If you combine access with recent breakup, or access, intoxication, and recent breakup, take any of these four, making sure that one of these is access to means, you have an explosive mix on your hands right there. So let's talk about some more detail. We're going to talk about access to means again in a bit, but let's talk about things other than means. So where do you typically see proximal risk factors? You typically see them around times of transition, which would be, think of the patient who was inpatient for whatever reason, say for depression, and is now transitioning to outpatient, but hasn't quite transitioned. A kid that was placed in, has just been removed from home and is placed in, so transition implies or refers here to transitions in levels of care. Another good example, I'm talking to now my primary care colleague, those of you who are here today, that's the transition of when you notice something funky in that appointment and you say, well, why, we need to refer them to psych, or refer them for psychotherapy, or refer them to your behavioral health, whatever. That is a transition in the level of care. And a lot of times that transition never happens. So you've charted, you've made that note, you have, tasked it to your nurse or whoever, and for whatever reason, that didn't happen. So that is the transition that I'm referring to here, and that's a risk factor, because that is where you can lose patients. Sleep. I call sleep the great equalizer, because when nothing else works, if you can regulate sleep, things are almost always going to be better and improved. So when you take your history, proximal risk factors include recent disturbance in sleep, and we'll talk more about that. Back to access to means, substance use. How adherent are they with treatment? Is there immediate conflict in the family or in the work environment or at school? Sleep, this is a big one, friends, because let me ask you a quick question. So what do you guys think is between the two, one of the bigger, more significant predictors of self-harm or suicide? Insomnia or sleeping too much?
A lot of insomnias and a couple hyper insomnias.
Okay, awesome. Anyone else? So you would be correct. And we've got some numbers. But this is the key here. Any sleep disturbance in the preceding week among youth who died by suicide versus control. This is what we saw. We've talked about that. It's interesting, anytime I talk about access to means, automatically the thought is we're talking about firearms, but we're not really. We're talking about any lethal means, lethal drugs. I tell parents, you know, everybody, if you have medications at home, you need to have a lockbox for medications. Doesn't necessarily have to be opioids or anything like that. You have kids at home at whatever age, they're either going to be toddlers or school-age kids or teenagers. And all of those ages have impulsivity and reactivity, part of the developmental phase. And so you want to keep lethal means very, very far away from them, very far away. So this is not just firearms. Before I go any further, I want to ask, what do people think? So excuse me. Research shows that if a gun is present in the home, it is more likely to be used as a method of suicide. Conversely, in the absence of firearm in the home, firearms are rarely chosen. So if you don't have firearms in the home, it is not likely that the person's going to go out looking for them, because suicide very often is an act that occurs within a small bubble of time. And once the impulse passes for in that moment. But in that moment, when the impulse is building up, having access to firearms is really likely to lead to a fatal result. Suicidal youth, 3 times more likely to make a lethal attempt, obviously, if there's a gun in the picture. Lethal drugs, the availability also increases the risk for a lethal attempt. And when I say that, I'm aware of the fact that, you know, if somebody, and I've heard people say this before, you know, if a person really wants to, you know, end their lives, they're going to go find something to do so. And that is true. But things like having bleach at home, right? Most people do. It's there. Do you lock up all the time, all your bleach? Probably not. How often do kids go and find bleach? It does happen. I've seen that happen. But we're talking about the lethality and the lethality and the severity of attempt. So the higher the risk of whatever means they choose, the more fatal that outcome is, the higher the risk is, if that makes sense. Bleach typically is nasty to drink. I've had patients who've done that, and they'll tell me, I'm never going to do this again. I learned my lesson. My patients, unfortunately, I haven't lost any, knock on wood, to suicide, but those who have attempted have said, it was there. I was really angry, drunk, mad, sad, hopeless. And it was there, and it just seemed really easy. And yeah. So let's talk about safety planning. How many of you have safety planned a patient home? And could we get some answers in the chat maybe, or?
Yeah. One person says, yes, I have. Yes, we use them with every patient.
Awesome.
That's a yes, many times. I have many years ago.
And so let's talk about what are the elements of a sound safety plan, because sounds like people have used safety planning, which is awesome. Anybody wants to, any thoughts about what is a good safety plan, or just some elements of a plan?
Creating awareness, the individual faces, suicide hotline, getting consent to ask family and friends, teach your support system what your triggers are to call someone.
Excellent, great. So sometimes when I do this presentation, people get stumped here because I ask them who needs to be involved. And I get all kinds of very, very good answers, involve the parents, yes, involve the school, the teachers, yes. And I often say, but what about the person that you're making the safety plan for? And you'd be surprised how that isn't necessarily something that comes to people's minds. And it absolutely has to. I mean, safety planning for an individual starts with that individual. And if a patient is unable or not capable, unwilling to engage in safety planning, then you have a real problem on your hands. I typically, but granted, I work, in specialty mental health. If I can't engage the person that I'm trying to keep safe in my safety planning, I am reluctant to discharge them home. I would go for a higher level of care at that point. That said, most of the time with youth, they are willing and able and ready to be involved, provided we ask them. And what is the role of technology? I just did a couple segments on one of the radio, actually a radio station in Detroit, but also for one of the TV stations in Lansing about screen time now that it's summer and kids are at home. And I talked about, having a tech-free zone at home. Parents need to create that 2 hours at least of no tech for parents and kids, blah, blah, blah. But here we're going to talk about the joys of using technology, because there really are some good things about technology when we're safety planning. So this is a sample safety plan format. Of course, it starts with removing lethal means, recognizing signs, personal coping strategies, interpersonal, who can you call, and contacting a professional. So this is really cool. You can have different versions of it, but they pretty much have these same elements. Every plan begins with the removal of lethal means. It's really tough on families sometimes because we're saying remove lethal means, and they're saying, well, what about forks and knives? And what about scissors? And what about staplers? And I mean, it can get pretty involved and really distressing for families. Recognizing warning signs. And this one, it really, well, actually this and this, these two are really where we involve the patient, provided they are willing to be and able to be involved. So what do you feel when the last time you felt like you wanted to die? What did you feel in your body? What did you feel in your mind? Was it preceded by, does it always happen if you have a fight? Does it always happen when you're on TikTok or Instagram, whatever else is out there, somebody saying something bad about you? Recognize those warning signs. And then what do? You'd be surprised sometimes saying, can you just try to switch off and stay off that whatever social media? I'm told kids don't use Facebook anymore. It's the parents who do. So it's mostly TikTok and Insta. And whatever, so some other thing that I can't remember the name. But saying something like, well, how about coping by blocking that person or disconnecting for a little bit? And then who can help you disconnect and block? I'm just kind of using that trigger as an example. And then who can you contact for help? The suicide hotline, actually, I'm finding more and more, 988, a lot of my patients have utilized it with good results because they were thinking about it. We had talked about it and they found that they could just text that number and in that moment passed and there was support and there was no adverse outcome. So safety planning in the office, this is where my residents, when I teach them, I work a lot with pediatricians and peds primary care people. This is where most people have questions and get really, really nervous. What do I do in the office? I mean, can I call you or who do I call? And I say to them, you know, to do good safety planning in the office, you should have a plan before the safety plan. Have a plan for how are you going to approach the question of suicide, and then how are you going to respond to it. I was with some residents and we were, you know, they were seeing patients as observing, and I said to a few of them, said, well, I noticed that you didn't really clearly ask about suicide. And one of them chuckled and said, yeah, I know. I just kind of just pussyfooted around it because I was afraid of the answer. What if they said yes? What am I going to do then? And I find that is true for a lot of us, including myself. You dread sometimes asking that question because, geez, it's 4:30 on a Friday. They say yes, and there goes your Friday. So have a plan. How are you going to ask and how are you going to respond? Have a list of questions in your mind. Write them down even. What are some things that will help you quickly triage how serious is this? So have you thought about hurting yourself? Are you thinking about it now? If you are, do you think you have a plan? Do you have a plan? What is the plan? Do you see yourself acting on the plan? How do you see other people responding to whatever it is? So, you know, having those kind of questions, rehearsing them in your head, so then it's easier for you to quickly go boom, 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 down a list of questions. And each question will give you a little bit more information. Designate a staff. I say this to all my colleagues in primary care. Have a plan for yourself, but designate someone in your office who is trained in mental health first aid. I'm a huge fan of mental health first aid. It's a training, it's an 8-hour training. Pre-pandemic, it was only available in person. During the pandemic, they really developed an online delivery. And so that's now 4 hours, I think, that is synchronized, and then 3 or 4 hours of asynchronized work that you do for the training. But most community mental health clinics, I think the rural health extension office actually does it free of cost for anybody. So have staff that are trained in mental health first aid. That goes a long way. Of course, involve and educate parents and guardians.
We do have 2 questions in the chat. One hand raised, so you can, Gail, if you want to come off of mute, go ahead.
Sure, thank you very much. Hi, Dr. Alavi. I just first wanted to say I met you back in the 90s in Hillsdale. We used to consult on some of our cases at our agency.
Oh my goodness, who's this again?
Gail Greer was my name at the time. Now
yeah, I remember you, Gail.
You have not changed a bit.
Oh, okay.
I just want to make a comment about
older and wiser, but yeah.
What's that?
I said older and wiser, I hope.
Oh yeah, I hope so too.
Yeah.
I wanted to make a comment about 988. About a month ago, I have a non-binary 17-year-old client who has been in psychiatric hospitalization about 3 times in the last 4 years. And I decided to try 988 myself. So I called it because I wanted to tell her what my experience was. And I was thrilled that they had, for this, you hit 1, or they hit a phone tree basically. And the exciting thing I heard was for youth under age 25 that are LGBTQIA, press this one. So that told me that there were staff especially trained to help those kids and young adults. And I thought that was great. And they also said, since you're calling, we want to ask you if you're okay, which I thought was great because I think they have sometimes people say they are calling for someone else. And they were wonderful. I can't say enough about it.
Thank you for sharing that, Gail. I had the same experience myself because I was trying to test it for a patient, and I actually was at a meeting last week, and another physician said that they were testing it out for a patient and had actually the same experience almost that you had, Gail. So I can't say enough good things about it either. It's a good, really, really good resource for all of us. And then there's another question.
Yeah, it says, isn't there a protocol in the office like in the hospitals? So I'm thinking, is there a protocol in the hospitals for certain like assessing those patients?
It depends on the hospital. Could someone speak about that? I'm not sure
This is
which
Autumn
hospital.
Brown. So you were mentioning that your colleagues or a variety of colleagues are kind of leery about asking questions to patients. I know part of it has to do with it's Friday at 5, now what? But you shouldn't be just winging it, right? There should be a specific process. You shouldn't be trying to guess what you should ask. It should be A, B, and C, and then based on that, here's what you do. So I guess I'm just worried if people feel like they're winging, trying to help someone in a mental health capacity, because I don't feel like that's good for either side. Does that make sense?
Absolutely, yes. And I find it more in primary care settings, because if it's especially mental health, we think we're all trained. We have a protocol in our heads. But you'd be surprised to know, I don't know how many pediatricians are here, but this is not something that's taught in primary care. There's no training for any of this in residency for any of this. Do you know that?
Right, but with new statistics, there has to be that continuing education. So now that
Yes,
there's a new or updated problem, we have to help assist those that are meeting those patients where they are. Since the numbers are alarmingly getting worse, we can't just say, well, you didn't get training in school, so don't worry about it, right?
Amen. That is why I'm here today. That is why we have the grant that we have. That's what we do with MC3. But that's why we need to have these talks, these grant rounds, these trainings at every level. So the residents, the practicing physician, the nurses, the ED docs, the ED staff, your front office. There are levels of this, and which is why I'm a big fan of mental health first aid, because there are levels of it. They have those for police and firefighters and healthcare workers. And we actually started to tweak it for our medical students. So there's a lot of work happening in the country, but I know in Michigan, I'm not the only one, but I am one of those people that is working at a very basic level, not just working with the trained physicians, but actually we started working since 2016 with our incoming freshman medical students, getting them trained into mental health first aid, so that when you go and ask a patient, how do you ask and what do you do? So we're doing a lot, but we need to do way, way more. You're absolutely right. Absolutely correct. So this is also kind of ominous and alarming, that the largest sentinel event in suicide attempts is failure to assess, and that most suicide deaths occur due to poor screening, assessment, and management in the primary care setting. Again, kind of, what we just now talked about. So definitely talk to your patients. Discussing suicidal ideation does not make patients suicidal. Now, this group sounds like it's pretty well informed, but I've had this question come up several times, and it's a valid question. It's a scary thing to bring up suicide, and you certainly don't, do no harm. So, but asking does not make people suicidal. Collaborating with your patient is the name of the game. This happens a lot, actually. It's medicine and healthcare sometimes can be pretty authoritarian still. I am going to tell you how you're going to live. I am going to keep you safe. It's my job to make sure that you live. Well, it's our responsibility to help our patients to lead better and healthier lives, but we can't do this if the patient doesn't want to do it. So collaborating with the patient, not telling them, is the way to go. And then, strategize, work with them to manage what happens between visits. It's really important to do that, by the way. It's even more important for us in specialty mental health care, but definitely for you guys as well. And then identify steps to limit access. Can't say this enough. And then what doesn't work? So these no harm contracts, I don't know, does anybody use them? They're still fairly common. I was talking to a group of primary care docs this morning, and one of them was talking about how they saw a patient who came in, immigrant, spoke, English was not their primary language. And the wife said that she was suicidal, and the husband said that he was homicidal. And the wife was given an SSRI, and the husband was given something else, an antipsychotic. And it was I said, it really alarmed me, because when I said, well, but maybe they should be sent to the ED with at least the person who's going to kill the wife and the children. And they said, well, no, because we sent them to talk to the behavioral health consultant, but then also we made a no suicide contract. That's not going to do anything. That is not going to do anything. And so don't feel bad if that's something you've done. It's okay. People don't know, right? This is not common knowledge, but those no harm contracts mean nothing. They are ineffective. They can actually be harmful because they give you a false sense of safety and security. Have a different plan that does not involve a no harm contract. So I'm not going to read this. You guys, I'm sure, can see. So as I say, this is all good stuff, right? But when I'm talking to my nurses or to our students and residents, we talk about, when we do talk about antibiotics or whatever, we talk about the number needed to harm and number needed to treat, right? So to say how safe or how effective a medication is, how many patients need to be treated for someone actually to get better, and how many patients were harmed before one person got better. So the number here for using a suicide prevention model, which was based on safety planning, that every 3 adolescents, so number needed to treat was 3. For every 3, you could prevent 1 suicide attempt. That's pretty good, right? If you had an antidepressant or any pill that the number needed to treat was 3, I mean, it would be a gold mine. Most medications don't have number needed NNT of 3. It's way more. So this slide, I say, we're almost to the end. At least ask 3 things. Make time. What kind of ideation do you have? Is there intent? And is there plan? These 2 things at the end, I say, just to give you some words, some ways to frame your question. Putting it in context is a really good idea, because it destigmatizes and makes them more comfortable saying what they are saying. If you are horrified, not that you would be, but I see that sometimes in my residents, actually psych residents, when they're starting out, they look horrified, like they look absolutely petrified when someone says, yeah, I'm thinking about dying. So think about that, put it in context for them and for yourself. It's not uncommon. It does happen. This is a painful situation. And then let's shift the frame and say, well, so how bad is it? How intrusive are the thoughts? Do they go away if you talk to a friend or if you go work out? Or are they more, they have this quality of pressure where no matter what you do, it just keeps popping in your head? And if they say that that is the case, that's the patient you want to actually hospitalize right then. You don't want to let them leave your office. So these are some resources. And this is my last slide. You guys will have, the slide deck, I believe, right?
Yes.
Okay.
I sent it out this morning to follow along, but then in my follow-up email, I will also attach the slides as well.
So we're at the top of the hour. I don't know if I have time for questions. I think I can make the time, a few minutes at least, if you guys can.
Yes, we are available to stay on for a few minutes. If you have any questions, please feel free to ask away. I'm also going to share my screen. Except for some reason, my screen is not updating with the PowerPoint. For the QR code, I know it looked like the QR code was not, or the link was not working. So I'll get that to you guys. But please feel free to come off of mute, just say who you are and ask your question. And also type it in the chat as well.
Hi, my name's Dawn Lambert. I just wanted to say thank you very much for this. I appreciate it a lot. I have 2 teens. I'm a nurse. I think it's very beneficial to have this. So not just to you, Dr. Alavi. Did I say that right?
Alavi.
Alavi.
A lot of patients, my patients call me Dr. A, and my students do too. So.
But I also want to thank MSUCon for putting this together as well. So thank you very much.
You're very welcome. Wow, I answered all the questions. Amazing. Okay.
It does look like there might be a couple in the chat popping up.
Okay.
One says, I wanted to ask what age the impulsivity that is characteristic of adolescence ends.
Yeah, right. It depends on the adolescent, and you'll see, you can tell, because if it's your own child or if it's a patient, you can ask the parents, when are they more stable? I'll give you an example. I have a niece who's 13 and already much less impulsive than my son who's almost 30. So, and a physician. So there you go. It really depends. Biologically, nervous system, brain wise, they have this arbitrary age of 18 and then 21. There is some validity to that, because that's when a lot of the tracks have matured between the frontal lobe and the midbrain and in between the 2 hemispheres. So typically, if all goes well, around between 18 to 21, but then it really depends. But I'd say if you're still seeing a lot of impulsivity at 18, it should start to settle down by 19, definitely be much, much less by 21. And if it isn't, then you have a different issue. Maybe you have undiagnosed ADHD or depression or something, right? Or maybe there is history of trauma. And what was the other question, please?
So the other one says, excuse me, with something like Prozac or Lexapro, I know it can make people tired, but is there a way to have it balanced better so that they don't feel exhausted all the time?
That's an excellent question. The answer is yes and no. Yes, there is a way, and that way is you start very low. You know, people think that. So when you look at the package insert, I'll use the example of fluoxetine. They say the dose is 20 to, I don't know what they say now, 40 or something, right? So keep in mind that the package insert, the dose that they tell you about is the dose, is not the starting dose. So you want your starting dose to be way, way lower. High doses lead to more treatment emergent side effects. Fatigue is one of them. So low dose, give it lots of time. Keep in mind, none of these medications work quickly. So just because, again, I'll use the example from this morning. I was talking to some physicians, and one of them said, well, I started so-and-so on a higher dose because they were really depressed. And I said, well, just because they're really depressed is not going to change how quickly the meds would work. What you've done, it may help if you wanted the patient to be really sedated, and they did, because then you'll get that antihistamine effect, and that's fine. But if you didn't, then all you're going to get is a patient who's really annoyed because now they are tired and they didn't bargain for that. So keep the dose low. Excuse me. Talk to your patients, educate them about the side effect, and know that most of the fatigue part goes away if you take it regularly and if the dose is not too much.
Thank you
Is that it?
so much for being here today.
You're very welcome.
we
Can I get a
truly-
list of everybody, please, just for my data collection piece?
Absolutely, we can do that.
All right. Thank you, everyone. Bye-bye.
Have a great day.